Thanks to all of you that you could make it today and join this very interesting webinar together with Professor Dani. The topic will be very interesting, I promise you. Maybe let me start by introducing some kind of rules for this meeting. So what we will have today is we will have the presentation from Professor Dani. Topic is here, Prozepsin in neonates. I will explain a little more in detail later. After his presentation, we will have another short presentation from our distributor, JEPA, in Italy. It's more about the sampling options we do have in neonates, how to handle this, you know, what are benefits from PATHFAST point of care Prozepsin in comparison to waiting for lab results for a longer time. That means we will have two presentations, a longer one from Professor Dani and a shorter one from our Italian partner. For this, I would like to ask you to put your questions into our Q&A session. This is the option you have in the Zoom function. Of course, I suppose all of you know this. Just state questions there, and we will follow up all these questions after both presentations, okay? So we will have enough time to follow all of these questions, and can assure that everything will be answered properly, okay? All right, so let me start then with a short introduction of Professor Dani from Italy. So Professor Dani has several positions and functions. He is from the Careggi University Hospital of Florence in Italy. His functions are, for instance, he's a full professor of pediatrics and director of the Division of Neonatology and Neonatal Intensive Care there. And he is also the director of the Department of Neuroscience and Psychology in Florence, okay? More than that, he's the coordinator of the neonatal network of the Tuscany region and member of the Birth Commission of the Italian Ministry of Health. Okay, so regarding his topic for today, it will be Prozepsin as a diagnostic tool for sepsis in preterm infants. So what we will learn today from Professor Dani are several things. For instance, he will give us several information about the common use of the reference ranges of Prozepsin, the accuracy of Prozepsin in an early onset sepsis scenario in neonates, and the same for the accuracy of Prozepsin in a late onset sepsis in neonates, okay? More than that, he will also tell us something or explain about the benefit of having Prozepsin in comparison to other biomarkers, common biomarkers like CRP or also PCT. Okay, so this will be the topic for today. After this presentation, as already shortly mentioned, we will have Ricardo Figes from JEPA, and he will explain more about the options for the sample material, you know, how to use it, what can be used, for instance, can we use capillary blood, what are benefits of the point of care Prozepsin of PATHFAST, and so on, okay? And as already explained, after that, we will have our Q&A session. Okay, so then now I wish all of us a very interesting and good presentation time with Professor Dani. And I would like to hand over now to Professor Dani. Okay, please, Professor, start your presentation.
Many thanks, Frank. I will try to share my screen. Can you confirm that my presentation is sharing?
Yes, it's perfect. Thank you, Professor.
Okay. First of all, I want to thank Frank and other organizer of this webinar because he allows me to share with you my presentation today about Prozepsin as a diagnostic tool for sepsis in preterm infants. This is the outline of my presentation, and we can start with the background. Which is represented by the fact that sepsis can cause high rates of morbidity and mortality in neonatal intensive care units. As you know, early onset sepsis incident Incidence is reported to range from 0.5 to 1 in thousands births in fertile newborns, but it is more frequent in extremely preterm infants, and at 22 to 24 weeks of gestational age, the occurrence of early onset sepsis ranges from 3 to 4%. Case fatality rate of early onset sepsis ranges from 0 to 3% in term infants, but it is higher in preterm infants, ranging from 55% in 22-24 weeks of gestation infants to 30% in more mature infants who are born at 25 to 28 weeks of gestation. However, survivors are also at high risk for long-term neurodevelopmental impairment. The occurrence of late onset sepsis is quite higher than that of early onset sepsis because it can affect from 3 to 25% of very low birth weight infants and is inversely related to the degree of prematurity. Related mortality ranges from 2 to 50%, depending on the aggressiveness of the pathogen, the length of the hospitalization, and the age of the neonate. Unfortunately, the early diagnosis of sepsis in neonates can be a challenge because of its specific clinical presentation, low sensitivity of blood culture, and the poor performance of the currently used marker of infection, particularly during the first day of life. In fact, serum level of PCR and of CRP, and PCT show a physiological increase during the first 48 to 72 hours of life and are affected by several maternal and fetal pro-inflammatory conditions other than infection. For this reason, in many cases, empiric antibiotics is prolonged in preterm infants in order to prevent early onset sepsis. But early broad-spectrum antibiotic prophylaxis without proven sepsis was shown to be associated with adverse outcomes during the first week of life, such as late onset sepsis, necrotizing enterocolitis, chronic lung diseases, and death. Moreover, high antibiotic utilization rate was also associated with death or adverse neurodevelopmental outcome at 18-21 months of life. Moreover, in the long term, adverse effects of prolonged antibiotic therapy have been reported, such as an increased rate of diabetes, an increased body mass index, episodes of recurrent wheezing and asthma, and moreover, a higher risk of celiac disease and other inflammatory bowel disease. One of the most reported mechanisms of these harmful effects is the perturbation of gut microbiota. Since antibiotic-induced gut microbiota dysbiosis in very preterm infants have been linked to the pathogenesis of NEC, LOS, and other adverse health outcomes. But what is presepsin? Presepsin comes from CD14, that is a member of toll-like receptor, which has two forms, membrane-bound CD14 and soluble CD14. CD14 has the ability to identify several groups of ligands of both gram-positive and negative pathogens, and the best studied ligand is LPS. Lipoprotein binding protein presents LPS to CD14, which is expressed at the surface of monocyte and macrophage, and the complex CD14 LPS LPB is then cleaved by cathepsin D and other proteases in plasma or in the phagolysosome inside monocyte and macrophage. And then a terminal fragment of this complex has been named presepsin. Presepsin has been studied as a biomarker of early onset sepsis, and in 2020 we published this paper in which we evaluated the reference range of presepsin in preterm infants during the first 24 hours of life. We performed a multi-center national study in Italy, in which we enrolled consecutively about 108 newborns with the gestational age equal or less than 32 weeks, and presepsin was measured at 0 to 6 hours of life, and then at 12, 24, and 48 hours of life. In the figure 2, in the left of the slide, you can appreciate the median values of presepsin at different study point and its interquartile ranges. We observed that the values of presepsin was similar at T0, T1, and T2, but it was lower at T3, at about 48 hours of life. Moreover, you can appreciate in the other figures in the right of the slide the distribution of percentile of presepsin that we calculated at T0, T1, T2, and T3. In our study, we observed that the presepsin level at TO during the first 6 hours of life are not affected by perinatal factors such as birth weight, white blood cell count, delivery mode, PPROM, intrapartum antibiotic prophylaxis, and antenatal steroids, in contrast to other sepsis biomarkers such as CRP and PCT. In fact, CRP has been reported to increase by 2.4% for each increase of 100 grams of birth weight, 0.5% for each hours of PPROM, 40% in case of antenatal steroid, and 28% in case of intrapartum antibiotic prophylaxis and cesarean section in uninfected preterm newborns during the first 4 days of life. Moreover, PCT level has been reported to increase by 2.2% for each increase of 100 grams of birth weight in case of PPROM and clinical chorioamnionitis. Thus, presepsin measured in the first 6 hours of life seems to be a more reliable biomarker of early onset sepsis than CRP and PCT, since it is not affected by the most relevant perinatal factors. In the table 4, you can appreciate the distribution of percentiles of presepsin at TO for each week of gestational age. Performing a multiple linear regression analysis, moreover, we demonstrated that only gestational age was significantly correlated with the presepsin at TO, T1, and T2 study periods, while at T3 study period, presepsin values were not correlated to all gestational to all tested variables, included gestational age. In 2022, we published this systematic review and meta-analysis whose objective was to assess presepsin accuracy for the diagnosis of early onset sepsis. And in the primary analysis among 12 studies and more than 800 newborns of any gestational age, we were able to calculate that the sensitivity and the specificity of presepsin in predicting early onset sepsis was 93 and 91% respectively. Moreover, we found that presepsin accuracy was not associated with the gestational age, methods of measurement, and the country where the study was performed. Therefore, we can conclude that presepsin is an accurate biomarker of early onset sepsis and that clinical trials are warranted to assess its usefulness and safety to reduce early antibiotic exposure due to the prophylaxis of early onset sepsis. Presepsin has been studied also as a biomarker of late onset sepsis. And in 2015, we published in Pediatrics this observational study in which we prospectively reported the value of presepsin in a cohort of infants born at equal or less than 32 weeks of gestational age who presented late onset sepsis in a period included between 4 and 60 days of postnatal age. And moreover, we also enrolled 21 uninfected controls and infected infants as controls. And enrollment at 1, 3, and 5 days later, we measured also C-reactive protein, procalcitonin, and presepsin in the infected infants, whereas presepsin alone was measured in the control group. And as you can see in the figure 1, we found that in infants with late onset sepsis, presepsin values were significantly higher than that reported than that found in control infants. And the median values of preseptin in infants with infection, with sepsis, was 1,295 nanogram per liters, and remained higher than that in the control group throughout the study period. Moreover, we evaluated also PCT and CRP values in the infected infants, and we found that these biomarkers did not change at T1 in comparison with the baseline values measured at T0, but significantly decreased at T3. The presepsin value, in contrast, slightly decreased at T1 compared to T0, whereas at T3 and T5 were significantly lower. We performed also the ROC curve analysis, and we found that the best cutoff value of PSEP, best cutoff in predicting probable late onset sepsis in our study was 885 nanogram per liters, with the specificity of 100% and the sensitivity of 94%. The role of presepsin in the diagnosis of late onset sepsis were later evaluated also by other authors, and Madaloni and co-workers in this literature review reported the cutoff value of presepsin in predicting late onset sepsis reported by Sabri and co-worker, Topcoglou and co-worker, and Astri Wanata and co-worker. All these studies found that the presepsin values was significantly increased in preterm infants with late onset sepsis diagnosis. And you can observe that the cutoff value of presepsin considered suggesting the diagnosis of late onset sepsis was similar in our study and in the Sabri and the Topcoglou study. This value was about half than the previous study in the study of Astri Wanata and the co-worker. These different results may depend by different study design or different methods for measuring presepsin, but it is very difficult to understand this similar difference, to understand the reason why. The reference range of presepsin was also reported after the first 24 hours of life, and this is important in order to evaluate the accuracy of presepsin in diagnosis late onset sepsis. Pugni and co-worker reported the distribution of presepsin in uninfected infants, and we can observe in the first table the distribution of percentiles both in term and in preterm infants. Other authors, as reported by Madaloni and co-worker in their review demonstrated that presepsin measured after 48 hours of life was not affected by relevant variables such as birth weight, white blood cell counts, delivery mode, steroids administered within 3 days prior delivery, premature rupture of the membranes, and intrapartum antibiotic prophylaxis. Moreover, other authors demonstrated that there is no correlation between presepsin and postnatal age after the first 2 days of life. It is interesting also to compare the presepsin accuracy with that of CRP and PCT. In this overview by Botondi and co-worker, the sensitivity and the specificity of CRP, PCT, and presepsin is compared both for the diagnosis of early onset and late onset sepsis. And in this review, the authors concluded that presepsin is a valuable diagnostic test for both early and late onset sepsis with higher sensitivity and specificity values than PCT and CRP, and that presepsin is a reliable indicator for antibiotic treatment efficacy monitoring. Ruand and co-worker confirmed this result, and as you can observe in the ROC curves, they found that only the combination of PCT and CRP or presepsin alone can improve the accuracy of diagnosis of neonatal sepsis. In fact, the area under curve for presepsin is 99%, and it is greater than that of PCT plus CRP, that was 96%, and higher than that of CRP and PCT alone, which were 85 and 91 respectively. These results are confirmed by Wesige et co-worker, which reported in this further review that presepsin has a sensitivity and a specificity higher than that of PCT and CRP. Moreover, they detailed that presepsin peak before PCT and CRP, and therefore can be used to monitor clinical response to therapeutic intervention prior to obtaining culture and result confirming it is a more reliable biomarker than CRP and PCT in neonatal sepsis. What are the future perspectives of the use of presepsin in the clinical practice? I'm happy to share with you the fact that we are performing in Italy the proposed study. In this study, we are enrolling, this is a multi-center randomized control study in level 3 neonatal intensive care units in Italy, and infants of 32 weeks of gestational age are randomized into 2 groups. The first group receives standard antibiotic prophylaxis for early onset sepsis. That is a combination of penicillin and aminoglycoside antibiotics. And the intervention group include infants who receive PCT and presepsis guide antibiotic prophylaxis. And in this group, we measured the presepsin values and the PCT values during the first 3 hours of life, and we decided to give antibiotic only in case that this value is exceed the reference value. That for presepsin correspond to 75 percentiles or reference range published by Poggi and co-worker in 2020. And for PCT correspond to the 97.5 percentiles or reference range reported by Chiesa and co-worker in 2011. The primary endpoint of this study is represented by the change, the difference of composite primary outcome from the two groups. And this composite primary outcome is represented by the survival without major morbidity occurrence. And the major morbidity has been defined as the presence of any of the most frequent complications of prematurity, such as higher degree of IVH, ROP, and NEC, occurrence of PVL, BPD, and late onset sepsis. This is the November monthly accrual report of the proposed study, and you can observe that at this time we have enrolled 48 patients, but today are 50 patients, and our study need to be prolonged because the population size is higher than 260 patients. Another possible perspective of the presepsin as a biomarker for sepsis is its measurement in the cord blood. In this study by Priolo and a co-worker, they were able to measure presepsin in the cord blood, and they reported the sensitivity and specificity of presepsin in cord blood. You can observe their values, their 15 centiles and 75 centiles values, and also the ROC curve. On the basis of their result, they concluded that cord blood presepsin could be a predictor of early onset sepsis in preterm infants and perhaps also in term infants. In conclusion, presepsin has been studied as a biomarker for neonatal sepsis, and the reference ranges were reported for both the first and subsequent days of life. Presepsin has shown good accuracy in diagnosis both neonatal, early onset, and late onset sepsis. And based on current clinical study results, most factors affecting CRP and PCT levels seems to not affect presepsin levels. Therefore, studies aim at investigating the role of PSEP in the clinical practice as an early predictor of perinatal sepsis and late onset sepsis are justified, and our proposed study is an example of these studies. Further studies are needed to establish a reference range for pathological conditions other than sepsis in neonates, such as surgical diseases, renal failure, congenital heart diseases, and perinatal asphyxia. It is important to underline that presepsin shows the possibility to get the result to the bedside within 50 minutes using a point-of-care device. And another advantage resides in the small blood volume, about 15 microliter, required for presepsin measurement. Finally, it is important also to underline that the cost per sample is similar to that of other biomarker sepsis, but this point will be elucidated by the next speaker. Thanks for your attention.
Thank you very much, Professor Dani, for this excellent presentation. I suppose there will be many questions after Ricardo's contribution now. So, but let us go now then first to Ricardo's presentation. Ricardo, could you please take over now? Thank you so much.
Hello everybody. Thank you, Frank, and thank you, Professor Dani, for your great speech as always. It's not a surprise for me. Let me just share my screen. Could you please confirm it is you can see?
Not yet. Now, there it is. Yes, I can confirm. It's there.
Okay. So also would like to thank Professor Dani because he introduced my very short speech about which will be the benefit of point of care for your patients or for NICU patients. So as Professor Dani says, the major of the study of presepsin are based on chemiluminescence immunoassay, which is the name is PATHFAST, which is the PHC instrument for the point of care for the immunochemistry. Sorry, I got some problem with okay, so so today the lab is, you know, for the biomarkers in neonatal environment is always let me say an issue, because sometimes you have to draw a very high quantity of blood samples from patients that are very, very low birth, so some less than 500 grams. And so it can be also true possibility. Say also that the mean time for laboratory it always takes time to get the result. This is an example for at least 2 hours, 1 hour, 2 hours, that for sepsis can be a great issues. And then for the NICU samples, for sure, for neonatal samples, there are always an issue about the hemolyzed samples that you send to the lab, and then the laboratory cannot perform the test because the sample is hemolyzed. So sometimes you also have with a lot of sampling to the neonatal patients, you can also have the neonatal anemia. So it is a critical disease for the patients. So as maybe most of you can confirm, the neonatal clinics are always in this kind of balancing. So maybe not to take to not have the laboratory data at the right moment, and maybe you are balancing in order to repeat high risk sampling or procedures. But thanks for the technology, there is the third way. So this could be a mini-invasive sampling with the point of care. So what are the benefits of the point of care in the NICU? Always, because it's always ready to use at the bedside, so it's always at your disposal. For sure, can give you the reduced blood volume of samples, which is critical for neonatal, and obviously you can have also a quicker result in order to have 50 minutes. So, but we are here in order to talk about the PATHFAST, which is we consider your sepsis platform. And this is totally a point of care system because the reagent and the test are ready to use. So we got the possibility to get from 1 to 6 tests at the same time, and we get always the result in 15 minutes. As Professor Dani says, the presepsin instead could be performed with just 15 microliter from blood gas capillary samples. Also, the device it hasn't no fluidics, so it means that is no any maintenance procedures or any trouble on maintenance it. And the last thing is that results are adjusted for the motor right value of the patients, which is very critical in the neonatal environment. Also, just to give you an idea, this device can also have other markers like high sensitivity troponin, hemoglobin, CKMB, and NT-proBNP, the dimer, and as we see, what is the sepsis panel. It is one of the most comprehensive testing panel for sepsis, because at the same time you can have the Brown's PCT, the presepsin, as Professor Dani says, and also the CRP in one platform. So one of the most important things that this point of care, this PATHFAST, can be very, very easy to use for the operators. So because from the sampling, because it needs just 50 microliter from capillary blood samples, as I told you, the blood gas capillary is perfect. Then you just drop and insert the samples into the cartridge, the single-use cartridge. Then place starts, and then after 50 minutes, you just read the result. So in very few words, with PATHFAST, you can have a comprehensive sepsis panel in the point of care. You have 3 markers for sepsis in one platform. You can have also in capillary blood, which is unique. You can have all of this result in 50 minutes directly at the bedside. And one of the most important things that all the all the data that are shown by Professor Dani are measured on PATHFAST. Also, the proposed study will be totally measured by the same device, which will be PATHFAST. So this will for sure give you a very robust result and very robust data in order to use daily the PATHFAST and the Presepsin in your day care unit. And so for us, and I hope so you, PATHFAST is the perfect NICU gift. And thank you. This is all. I'm waiting for your question.
Yeah, thank you so much, Ricardo, for this excellent presentation also. You know, it's very comprehensive and very clear, all the benefits, all the advantages of having Presepsin, and as you already explained, all the other sepsis biomarkers on board, you know. Yeah, perfect. So then now I would propose, please feel encouraged to state all your questions you have for both lectures from today. And yeah, state them as already explained in the Q&A function here of the Zoom setting. Okay. I have already one question for Professor Dani. Please let me state this one. The question is, thank you, Professor Dani. Can you please explain the apparent contradiction between the fact that it is not affected by chorioamnionitis and PPROM, but is instead sensitive via cord blood sampling? So what is the difference then here between the normal sampling and cord blood regarding the effect of chorioamnionitis and PPROM?
Okay, now the phone is open.
Yeah.
Many thanks for this interesting question. First of all, we have to remember that there are only a few studies. I know only one study in which the Presepsin values was measured in cord blood. It is possible that these apparently contradictory results may depend by the fact that in the studies by Priolo and a co-worker, the population which was enrolled was heterogeneous. For instance, mothers, pregnant mothers, pregnant women were enrolled if they had maternal chorioamnionitis, but in particular clinical chorioamnionitis, but also if they were inadequately treated with the intrapartum antibiotic prophylaxis, there was a lack of antibiotic prophylaxis as reported by CDC guidelines. Moreover, we can observe that about 60% of infants were preterm infants and 40% were term infants. Therefore, these results can be effective by this heterogeneous population. It is important, however, and by this point of view, I agree with the Dr. Dituri, that further study are necessary to elucidate the role of Presepsin in the blood cord. before to have a firm conviction about the value of this biomarker when is drawn from cord blood.
Okay, thank you. Understood. I have another question for Ricardo right now, and the question is, did you make a kind of cost analysis? It means more concretely the cost of lab for Presepsine, CRP, and PCT, maybe in comparison to the costs, you know, arising with PATHFAST biomarkers. Did you ever make some kind of cost consideration or cost?
Yes, we thank you for the questions, because it's always an issue, because honestly, for point of care means there is a lot of benefits in order to have the clinical outcomes, in order to improve the clinical outcomes. Obviously, we are in the time that you know, the administration of the hospital always look at the cost. For sure, point of care, I have an higher cost comparing with a typical laboratory test, because for the more productive, which is laboratory is more productive, more economic scale, you know, for the point of care, you know, the costs are obviously in the easy of use and the quick to have the result. So obviously the cost for the point of care are higher for sure. But if we get the result quicker, and if we can obviously take an action in order to improve the clinical outcomes, maybe also what is Professor Dani is trying to see with the proposed studies, in order to avoid some antibiotics prophylaxis to some patients. At least we have to see how many and the percentage, in order to avoid the antibiotic therapy, which will be decreased for sure, also in terms of cost, but in order also in terms of costing in the future, because we are reducing the antibiotic resistance. For sure, there is a lot of advantages beside the cost. So that's what we are trying to do today in order to have the best cost analysis.
Okay, understood. Yeah, very comprehensive answer. Thank you for this, Ricardo. I have another question, or this is more than only one question. Maybe already partly answered, but let's go through it quickly. So I have here, how expensive is this per patient? Is one. And of course then, but partly already answered by Ricardo, how much blood is required per sample? Are there any known interferences in taking the sample, like vaseline use, arterial, venous, capillary sample? It means, are there any differences, interferences observed? PN administration in the limb. Okay, and of course, is Presepsine as sensitive versus the Kaizen neonatal sepsis calculator? Suppose this is a kind of score, which uses both clinical and anamnestic data. So maybe, Professor Dani, do you have any experience for the last one, for instance? Is Presepsine as sensitive versus the Kaizen neonatal sepsis calculator? It's a combination, like we know from other scores, maybe. Do you have any experience here to compare? Oh, sorry, you are muted. Could you please unmute?
Sorry.
Yeah, no problem.
No, unfortunately, we have not experience with the Kaiser calculation, and therefore I cannot sound answers about a possible synergistic effect of the use of the calculator together with the Presepsine. This possible interactive effect, synergistic effect, could be the objective of next study, future perspective of Presepsine.
Yeah, indeed. So I had already in the past I had some kind of requests or answers or questions like this, but indeed, as you already point out, this could really an interesting point for future investigations. Indeed,
Yes,
this is nice. So we have some comparable things with our troponin test, compared to scores, etc. This could be a very interesting one for the future.
Yes, I agree with you. It is very important to evaluate the possibility of having more than one indicator. Therefore, it is important to consider not a single biomarkers, for instance, but different biomarkers, but also other tools such as Kaiser calculators.
Yeah, absolutely. Okay, let's have a look at the other part of the question. It's here indeed. It's how much blood is required per sample. So if we should state a volume here, so Ricardo, what do you think? We had this also in your presentation.
Yes. For the Presepsin,
Yeah.
means only one test is it's the minimum required is 50 microliter comes from capillary blood samples, but also we have experience on arterial, venous, or capillary samples, which is perfectly matched within the different samples. So it's the same. So arterial and venous are not changing anything.
All right. And how expensive is this per patient? I mean, can we answer this question? I'm not sure about this.
It is an international point of view. This is quite difficult to do in order to say something. But anyway, it is
Okay, then let's skip this question. All right. But I have another one. So, but already partly answered. So Presepsin was evaluated on arterial, in brackets, maternal or venous fetal cord blood sample. So was it then arterial from the mother, so maternal, or venous fetal cord blood samples? What was this cord blood from?
I don't know, but I'm not sure. But in my knowledge, the sample for the measurement of Presepsin in the study by Priolo and the co-worker come from venous sample, which is a fetal sample. Okay. Differently, if you use arterial sample, it is likely that you are measuring the Presepsin of the mother.
Yeah, I think so, right? It's quite easy to answer, right? Okay, thank you for this. Okay, this one is more internal, but a nice one. Okay, so are there any more questions to be stated from the audience here right now? So if so, please do so in the Q&A field. Okay. Yeah, this one is indeed nice because it's in Italian, Italian language. Okay. So how can we manage this now?
Okay. One colleague of mine and a friend of mine, Marcelo Napolitano, asked to me why Presepsin, which has been reported with 100% specificity and 94% sensibility, is not considered the gold standard for the diagnosis of sepsis. The reasons are different. There are many reasons. First, one is that this high specificity and sensibility was found in my study, but not in all study. Remaining study, however, confirmed that the specificity and the sensibility of Presepsin is higher than that of CRP and PCT, as I shown in my slide. And moreover, that Presepsin is not affected by several factors, perinatal factor and neonatal factor, which commonly affect PCT and CRP. However, as for all biomarkers, we need time before a new biomarker enter in the clinical practice. And the way to allow this entering is to perform studies such as the PROPOSE study. For instance, when we will demonstrate that Presepsin is able, together with PCT, in confirming or excluding early onset sepsis, I'm convinced that Presepsin can enter in the clinical practice. Other study, mainly in late onset sepsis, will allow a similar progress. The difficult is to build this randomized control study, to organize this multi-center study that need resources and that are difficult to plan. But I'm confident that in the next years, the role of Presepsin will increase and neonatologists will learn to use this biomarker in the diagnosis of also of both early and late onset sepsis, not alone, but together with the clinical science and together with the other biomarkers.
Okay, okay, very interesting answer. I guess it's clear. I have another one, and it's about the gestational age, the GA. And the answer, the question is here, the smallest GA that has been used in 23, 25, 26 weeks. Is there a limit?
We calculated and published the reference range of preterm infants during the first 2 days of life, and we reported the percentile distribution from 23 to 32 weeks of gestation. Therefore, my answer is that for the first 2 days of life, and therefore, in order to exclude or to predict the risk of early onset sepsis, there are no problems with regard to gestational age. My answers regard to the values of Presepsin after the 24 hours of life is similar, because the reference range published by Pugni and co-workers reported that there are no correlation with the gestational age and with the postnatal age. And therefore, we are confident that it is possible to measure with accuracy the value of Presepsin in all gestational age and later in the postnatal age.
Okay, thank you for this answer. Ricardo, there's another one for you. Life sites using the path with regard to the ease of you. Yeah, so basically it's about the convenience or for using PATHFAST. It's here, what about feedbacks you received from the customer sites, using the PATHFAST system in terms of, the ease of use, the benefit and troubleshooting from end users. Yeah. Could you maybe state something for this question, please?
Yeah, so sure. So it's an interesting question, because point of care means practice in the clinical world. We got 15 years of experience with PATHFAST in different scenarios, different clinical setting, ranging from emergency department to ICU to in the late time in the neonatal intensive care unit, and we didn't find any kind of problems of issue in using routinely daily the PATHFAST. It's very easy to use. It's very, even in the neonatal care, which is the most critical patient that we have in the hospital, I think, it gives a very, very effective help in order to improve the work of the operators and the work of the clinicians.
If
Okay.
I can add something to the answer of Riccardo, I can say that in NICU, the nurses are confident with many point of care, such as blood gas analyzer or other instrument to evaluate blood cell counts or the measurement of CRP, and the learning curve of the measurement of presepsin is very short, and it is difficult that some nurses report a problem, technical problem of measurement. And also all the methods to obtain a blood sample are the common methods in the NICU. As Riccardo told some minutes ago, we can use capillary blood, venous blood, or arterial blood without any differences for the accountability of the results.
Okay. Excellent. Good. So, last occasion for last questions, I would propose. Are there any more questions from the audience right now? I don't think so. So, okay. All right. So then I would like to close the meeting for today. Yeah. Thanks to all of you, especially our presenter, Professor Dani, and of course, Riccardo, as always, for your excellent contribution here again for this webinar. Just to complete the scientific part with your experience, of course. Thank you for this, as always. And yeah, thanks to all of the people who joined us today. Thanks to all of them taking their time for being with us and learning from Professor Dani and Riccardo today. Okay, so then I say goodbye to all of you and see you next time for another interesting topic in our webinar Academy session. Okay.
Bye-bye.
Thank you. Bye-bye. Bye-bye.
Thank you.
Thank
Bye-bye.
you.